this in case you want to listen to it again. So I picked a few of the select questions from that in your resources. There is some practice questions for the motor system. I found some more questions, both for the motor system, basal ganglia, and cerebellum, that I'll scan in and post on there as well. In addition to those, but they don't have a key with them. But I'll either handwrite on a page or put a key at the end for those different sections, and I'll post those in that same practice question section for the motor system. Okay, on Isidore. So, all right, take a minute, read this one. Take your best guess, and then we'll. You guys, anyone want to take a guess? B. If you knew nothing about this person or didn't know all it said was that the neurologist suspects a disease at the neuromuscular junction. That's all you need to answer this question, is like, what neurotransmitter is released at the neuromuscular junction. It's always acetylcholine is used at the neuromuscular junction. So if you just do that one fact, you could get this question right. Does anybody want to guess what condition this person might be suffering from? We have mentioned it. It's an autoimmune disorder. It affects the receptors at the neuromuscular junction for acetylcholine, so that you don't have as many receptors binding to it. It starts with an M, myasthenia gravis. And you'll tend to show it, you'll see it first in their muscles that have to work all the time, because things like your ocular muscles, your proximal muscles, your eyelids to hold your eyelids up, those muscles are always on. And because they're always on, you'll notice them more because you're trying to secrete acetylcholine all the time on them, and you'll pick those up more easily and see weakness in those, especially the smaller muscles like that. You'll see that more than larger proximal and muscles and things like that. Eventually they can have some weakness in proximal muscles, but you'll see it in the smaller, always turning on muscles. You could pick them up first, those deficits, because of that lack of acetylcholine receptors. Next. Anybody got a guess? It's D, the medial areas of the anterior horn. So this is a person who has weakness of axial trunk muscles, so proximal muscles. The distal muscles are fine. And and sensation and deep tendon reflexes are also normal. Which of the following is the most likely location of lower if you just knew that if you just read the last sentence, you don't even need any information above. Which of the following is the most likely location of lower motor neurons? These are anterior horn cells, right, that innervate axial muscles. And so we're looking at where are the motor neuron pools that lie in that anterior horn. Remember, we had that picture of an arm in there like that. And so the lateral areas of the anterior horn, those anterior horn cells tend to go to distal muscles. The posterior part tend to go to flexor muscles. The anterior part tends to go more towards extensor muscles. The medial part tends to go more towards proximal girdle muscles, axial muscles. Those tend to innervate those muscles. So that's that question. Next. What do you guys got for that? D, rubrospinal tract. So stroke, any decorticate posturing, so like this. But it doesn't have to be on both sides. It could be one side. So if he has stroke on the left, you might see his arm up like this on the right and his legs straightened out. So, or it could be both sides if he's got a lot of swelling or something like that in the brain. So decorticate. Flexed posture of his upper limb is caused primarily by actions of, the only thing there that influences flexion of the upper limbs is the rubrospinal tract. And so with decorticate posturing is he's decorticate. He's lost the influence of his cortex. So his rubrospinal tracts, his red nucleus, normally they require a little bit of influence from the cortical spinal tract so they're not overactive. So you have the right amount of flexion. Well, when you lose some of that influence from the higher centers above them, they get too overactive and they create too much upper extremity flexion. So that's why this decorticate versus decerebrate. Decerebrate actually cuts off this rubrospinal tract so you don't get enough influence of flexors and you go into extension everywhere, okay? This is a case thing that's going to have some questions related to this. I think I have the case still on each of the questions here, so you can refer back to it, maybe not. So you got that 16-year-old, unconscious, multiple injuries, vertebral fracture, bony displacement, flaccid paralysis of the left upper extremity, and loss of pain and temperature and thermal sensation on the right side of the body, beginning at a vertebral level of about the C5 dermatome. Jesus. Talk about ataxia, man. A little dysmetria going on there. So let's just take this one question at a time. Don't just, you can answer these hardly without even having the case. So let's just, flaccid paralysis of the left upper extremity in this patient most specifically correlates with damage to which of the following? And there's a reason they put flaccid paralysis in there. However, I will say, because this is a brand new injury, two of these could be potentially right with this particular case. But anyway. Does anyone want to take a guess? It would be C. The anterior ventral horn on the left. That's where your lower motor neurons. This is flaccid paralysis. So if you see flaccid paralysis, you typically say that's a lower motor neuron problem. So this guy has a spinal cord injury, but at the level of that spinal injury, he also, that bony fragment damaged actual anterior horn cells at that level. Now below the level of injury, down below in his legs, he might have actually spastic paralysis, but at the actual level where his arm is in that C5, C6 region, he's got some flaccid paralysis. So if you just saw flaccid paralysis, I would say, all right, this is a lower motor neuron problem. Cortical spinal fibers, that's an upper motor neuron. Cortical spinal, those are both upper motor neurons, cross off. Anterior paracentral gyrus on the right. That would be, that's another term for that. The anterior paracentral gyrus is another term for like kind of the primary motor strips right in front of the central. But anyway, that one I wouldn't write it like that. But that's in the brain. That would be an upper motor neuron problem. So that one's off the list. So it's got to be in the ventral horn. It's got to be in the anterior horn or something that affects lower motor neurons, and that's where those are at. So then you just got to decide if it's on the left or the right. Well, once you're in the anterior horn, the left ones go to the left upper body. So it's got to be the left side. Okay. Now, because this is a new injury, he could be in a state of neuronal shock, and if you affected the cortical spinal tract in that, you could have flaccid paralysis initially. So that is a little bit of a mistake of this. They didn't nuance this question out enough. If you kind of knew that stuff, so it would be the cortical. Remember, by the time you're in the spinal cord, the cortical spinal fibers have already crossed over in the medulla. So you would, in order to get left weakness, you'd be damaging the left cortical spinal tract after it's already crossed over. It's on the left side. So here, if they had to answer two of the above could be correct, I would say it could be B or C, is what I could say, if it's a new injury, because over time, if they only damage the cortical spinal tract fibers on the left, eventually it becomes spastic paralysis. It wouldn't be flaccid paralysis. His arm would get spastic a little bit because you just damaged those upper motor neuron fibers. So. Uh-oh, no, I spoke too soon. Well, no, he does talk about it here a little bit. People got a guess? I kind of gave it away, sort of. D, the cortical spinal fibers on the left, because we're damaging the spinal cord. Now, we'll have a whole thing on spinal cord injury. This will be even more clear. So I don't necessarily expect you to fully comprehend this right now, but these are motor systems and motor pathways, and you still should know where these are running. And this is an upper motor neuron problem we're seeing. If you've got hyperreflexia and increased muscle tone, that's upper motor neuron. So it has to be an upper motor neuron. Posterior columns, that's sensation. Dorsal columns, that won't affect anything. Spinal cerebellar tracts, E, that's unconscious proprioception. That wouldn't cause that, so I can cross those two off. Anterolateral system, that's also sensation. It has nothing to do with spasticity and tone. Cross that one off. And I'm not going to throw those distractors at you from our last thing, sensory. Now, you still have to start understanding now, putting some of these things together, but I'm not going back to try to, trip you up with the sensory pathways in this exam. But now you are going to start to understand when you have damage to regions of the nervous system. There's both sensory and motor in there. The final exam will all be you have to put this all together in that kind of way. But we could easily cross off the sensory pathways there, and we just get down again. Is it right or left? Cortical spinal tract fibers. And if it's on the left, And then we're in the spinal cord, everything's crossed over. It has to be the same. So the left cortical spinal tract fibers are going to the left side of this kid's body. And so it have to be the left cortical spinal tract fibers that were damaged in this case. Now this is a sensation, but it's kind of... So this is pain and thermal sensations, pain and temperature. I always like to eliminate things that I shouldn't be paying attention to right off the bat, and then narrow it down to the ones I need to pay attention to. So pain and temperature can't be posterior columns, because that's proprioception. There's no pain and temperature in the posterior columns. It can't be the spinocerebellar system, because that's unconscious proprioception. They're not even feeling that stuff. So now I'm down to A and E. And again, it comes down to a left and right is all I need to figure out here, is left or right. So this is damage to the spinal cord. And this kid has got loss of pain and temperature on the right side of the body, below that level of that lesion. So pain and temperature comes in on the right side of the body. Where does it go? Crosses over to the left side of the spinal cord immediately and starts going up, and it's getting blocked on the left side of the spinal cord. So this would have to be the left, the anterolateral system on the left is what would cause. So the spinothalamic is part of the anterolateral system on the left side of his spinal cord would cause a loss of pain and temperature on the right side of the body. Does that kind of make sense? What's the answer? Rubrospinal tract. What does it do? D, excites flexor motor neurons and innervating muscles of the upper extremity. So all of this stuff is just gobbledygook BS. You don't even need any of this stuff about what it does or what DC, and none of that. All you need to know is what's the primary action of the rubrospinal tract. So don't let certain things, distractors, I won't typically do that. This particular book likes to throw a lot of extra information that's not necessary, but it's just asking you what is the action of rubrospinal tract fibers. And if you know the rubrospinal tract tends to create upper extremity flexion, then D would be your answer. Here's a nice level 1 question for you. Anybody got an answer? Be C. Gamma motor neurons are the ones that innervate the interfusal muscle fibers. So C. Another case for us. So does this constellation of symptoms start to make you think what this person has? What do you think he has? Okay, I agree. I'm underlining that word. This one? Titubation is not the answer, but you don't learn. I'm trying to remember what it is now. I've looked it up before, but I've forgotten. I guess I can look it up on my phone, huh? A nodding movement of the head and body, especially as caused by a nervous disorder. So a nodding movement. But what did you guys say for the inability to initiate the movement? B, akinesia. Akinesia is without movement. So the akinesia is the initiation delay. Then once they start moving, if it's slow, that's the bradykinesia. Oh, I just answered the question for you. It would be bradykinesia is what this is. The velocity and amplitude is decreased, so it would be bradykinesia. So the type of gait that they display, and they start to like get faster and faster because they can't catch up with their center of gravity as they kind of fall forward. Because walking is a controlled fall. You catch yourself, and what they do is as they start walking, they're taking these small shuffling steps, and then eventually their center of gravity gets in front of their steps, and then they try to catch up, but they never take big enough steps, so their shuffling gets faster to try to keep up, and then it's just kind of sad. It's, you know, if they fall, that's not good either. But that's characteristic of what's called a festinating gait. That's the festination, where they start getting this faster little steps, trying to catch up with their center of gravity and not quite ever getting there. So. Don't worry about that one. What'd you guys say for that? E, the substantia nigra pars compacta. That's where your dopaminergic, which is the dopamine producing cells, are that project up to the putamen and caudate to excite the direct loop, inhibit the indirect loop. And so that would be the pars compacta component, or this, sometimes it's called the substantia nigra compacta. Some people call it the pars compacta. The substantia nigra pars reticulata is one way, or you call it the substantia nigra reticularis or pars reticularis. So those are kind of synonymous, but reticularis is, projects to the pedunculopontine nucleus and so forth. That's not where the dopamine producing cells are located. They're in the pars compacta part of that. Change this word, this synergy, change it to dysmetria. Dysmetria, because you don't know. Dyssynergy is another term similar to dysmetria. It's kind of. So this is a cerebellar lesion, right? Cerebellar lesions don't cause spasticity or spastic paralysis. These are not affecting upper motor neurons, okay? The cerebellum. This is the extrapyramidal disorder. It doesn't cause flaccid paralysis. We're not affecting lower motor. It rarely causes true weakness. That doesn't cause increased muscle tone or hyperreflexia. If anything, they might have a little lower tone and a little lower reflexes that are hard to even pick up. It doesn't cause a resting tremor. It causes an action tremor, right? You see it when they start to move. So it has to be dysmetria and decomposition of movement. That's what they're describing ataxia essentially there, is without saying the word ataxia. What'd you guys say? B, it's Purkinje cell. So the efferent neuron is going away from the, so it's going away from the cortex. So that's the, what takes the information from the cerebellar cortex and takes it away from the cerebellar cortex. And this is projecting towards one of the deep cerebellar nuclei. Okay, so the Purkinje cells are the efferent. That's how that gets out of the cerebellar cortex. The climbing fibers and the mossy fibers are the afferent fibers that go to the cortex. The Purkinje cells are what are efferently taking it away from the cortex. And all the rest of those are just interneurons that are in there, but they don't project out of the cortex to another structure. Okay. Well, does he feel motivated to study now after that?